All right, let's dive right into a really critical topic in obstetrics, antepartum hemorrhage, with a special focus on placenta previa. So picture this. A patient, third trimester, comes in with vaginal bleeding. It's an emergency and your brain has to work fast. What's on your differential? Is it placenta previa or is it abruptia placentae? Getting that call right is absolutely crucial. So in this explainer, we are going to master placenta previa from the ground up. So here's our game plan. We'll start with the basics of antepartum hemorrhage, then we'll put placenta previa under the microscope, break down its different types, figure out how it presents and how we diagnose it, cover the management, and then wrap it all up with a super high-yield recap for your exams. Okay, first things first. Let's build a solid foundation by understanding the bigger picture. Antepartum hemorrhage, or APH. So what exactly is APH? The definition you need to know for your exams is bleeding from the genital tract after the 28th week of pregnancy, but before the baby is born. That 28-week mark is the key here. It's the point of fetal viability, where the baby could potentially survive outside the womb. Now, take a look at this breakdown of the causes. When you think APH, you have to think about the placenta. I mean, look at that. Placental bleeding is the culprit in a whopping 70% of cases. And it's split right down the middle, pretty much 50-50, between placenta previa and abruptial placenta, each one accounting for about 35%. All right, with that context in mind, let's zero in on our main topic today and really define what placenta previa is. So what does the name even mean? Well, previa is a huge clue. It literally means in front of. In front of what? In front of the baby's way out. It's when the placenta implants way too low in the uterus, so it ends up partially or even completely blocking the cervix. Now, this is super high yield for your exams. Who is at risk? You want to think about anything that might have affected the uterine lining. Things like having had multiple babies before, being over 35, and, this is a big one, any kind of scar on the uterus, especially from a previous C-section. Even having twins, which means a bigger placenta, or smoking can up the risk. Okay, now we have to talk about the different types of placenta previa. And trust me, this isn't just for textbooks. This classification is everything. It tells you how serious the situation is and exactly how you're going to manage it. This diagram makes it super clear. It all comes down to one simple question. Where is the placenta in relation to the internal os? That little exit door for the baby. You can see it's a spectrum, from just being kind of low in the neighborhood to being parked right over the exit. Let's break them down. Type I is low-lying. It's nearby, but not blocking the door. Type 2 is marginal. It comes right up to the edge of the doorway. Type 3, incomplete central, starts to partially cover that doorway. And then you have Type 4, complete central, which is like a giant do not enter sign right over the entire exit. Okay, pay close attention here. This next point is a classic exam question, a real high-yield concept, because one of these types is way riskier than the others. We're talking about something called dangerous placenta previa. This specifically refers to a type 2 that's located on the posterior wall. So why is being on the back wall so bad? Well, look at this view. The back of the pelvis isn't flat. You've got the sacral promontory sticking out. So placenta back there actually squishes the available space, making it harder for the baby's head to come down and act as a tamponade on the bleeding. Plus, it really increases the risk of the umbilical cord getting compressed. Okay, we've got the theory down. Now let's get practical. How is this going to look when a patient actually walks into your clinic? And how do you prove your suspicion? This right here, you need to burn this into your brain. The classic description of the bleeding is sudden, painless, causeless, and recurrent. It's the classic tetrad. And the blood itself, it's typically bright red. That's a huge clue that tells you this is fresh blood that's getting out right away. And when you examine the abdomen, the findings are just as classic. The uterus is going to feel soft, relaxed, and not tender at all. This is the complete opposite of what you'd feel in a placental abruption, which is usually rock hard and painful. Because the placenta is taking up space down below, the baby's head is often way up high, what we call floating. Now, I need everyone to listen very, very carefully. This is the single most important rule. You must never, ever do a digital vaginal exam on a patient with suspected placenta previa. Not in the ER, not in the clinic. The only place this is even a remote possibility is in a fully prepped operating room, because you could literally trigger a massive, life-threatening hemorrhage with just one touch. And the great news is we don't even need to take that risk. Why? Because we have ultrasound. It's our gold standard. A simple transabdominal ultrasound is incredibly accurate. We're talking 98%. And it tells us exactly where that placenta is safely and without any risk. So your diagnosis is confirmed on the ultrasound. Now what? What's the plan? Well, management basically goes down one of two roads. And your choice of road depends on two big questions. Number one, how far along is the pregnancy? And number two, how stable are the mother and baby? If the baby is preterm, let's say less than 37 weeks, and everyone's stable with no major bleeding, you're going to play the waiting game. That's called expectant management. But if the pregnancy is at term, or if anyone is in distress, or if the bleeding is heavy, forget waiting. It's time for active management, which means one thing, delivery. And when delivery is the plan, how do we do it? For pretty much any significant previa, the answer is a cesarean section. It just makes sense, right? You're completely bypassing the problem area, avoiding what would be a massive hemorrhage during a vaginal delivery. It is by far the safest option for both mom and baby. Whew, okay, that was a lot of information. So let's boil it all down. If you remember nothing else from this, remember these key points for your exams.
Ready? Let's do a rapid fire. The bleeding, painless, causeless, recurrent, and bright red. The uterus, soft and non-tender. The big no-no, NO vaginal exams outside the OR. The diagnosis, transabdominal ultrasound. The one to really watch out for, type 2 posterior. And the management strategy, it's all about gestational age and how stable your patient is. Got it?
So you've got a really solid handle on placenta previa now. But the real test, the thing that separates the pros, is telling it apart from abruptio placenta. So just take a second and think, how would the pain be different? What about the color of the blood? How would the uterus feel on your hands? Nailing the difference between those two, that's when you know you've really got this down.